These education sessions, they are made possible by the Canadian Race Relations Foundation. We're very grateful to get a grant through them that has let us provide 6 Indigenous education sessions, all led by Indigenous speakers and developed by and through consultation with Indigenous peoples. So the Center for Race and Culture respectfully acknowledges that we are located on Treaty 6 territory and within the Métis homeland, that we all live and work on the traditional homelands of Indigenous peoples of Canada. We honor the elders past and present who call this land home and strive to understand our shared colonial history and work together towards a just future that includes and enriches all peoples. And if any of you are this is your first time seeing where Treaty 6 is located, it's located right here in Alberta, and it even stretches all the way into Saskatchewan. So it's a pretty big territory, Treaty 6, but it's very important to acknowledge the territory that we're on, and also too that it's located within what we call the Métis homeland in that regard. So if this is your first time attending a session with the Center for Race and Culture, or what we also call them CFRAC, for over 25 years, the Center for Race and Culture has brought together diverse people with an interest in promoting and supporting individual, collective, and systemic change to address racism and encourage intercultural understanding. Our staff, board, and members bring a range of expertise and experiences to their work with our organization. So, to let everyone know, this is the second Indigenous education session. This one is on medical racism and health equity. We are joined by Dr. Pam Roach from the Cumming School of Medicine at the University of Calgary. So I'm very honored to have Dr. Pam. I've been following Dr. Pam for a bit on Twitter. And even as I was telling her, my mom's been a fan of her too. She was telling me that she saw her on the Ryan Jesperson show and was like, you have to get her if you can. So I'm just very honored, very grateful. And of course, it's always cool to just connect with other folks in the Métis community also, establish that connection, and really wonderful to see all the work that's happening in our communities and all that we are accomplishing as Métis people, but also too, just as Indigenous peoples as a whole in that regard. So as I say, this discussion is on medical racism and health equity. And very, very grateful to have Dr. Pam with us. I am excited to learn a lot from her today. And as I say, there's just going to be a lot of wonderful discussions that will be had. So if any of you are unaware, Dr. Pam Roach, she is the Director of Indigenous Health Education at the Cumming School of Medicine. She is a Métis scholar and a member of the Métis Nation of Alberta. She has worked in the health services research for over 18 years in a variety of roles in academic and community healthcare settings, both in Canada and the United Kingdom. She completed her PhD in medical and human science at the University of Manchester before moving back to Canada, where she completed her postdoctoral fellowship in family medicine at the University of Alberta. She advocates for improving health systems safety or for improving health system safety by working at the intersection of health services and medical education to impact population and individual level health incomes. So reading that, as I say, like very much a huge fan of just the work that she does and what you have advocated for and continue to do so in that regard. It's very, it's a lot of important work that you are doing. It's what my grandma would call the good work in that regard. So when it comes to this session here, we usually like to do a little kind of preamp before I get or let Dr. Pam speak. And usually this will just give you a bit of information on kind of Indigenous experiences with the health system in general. So where I come from, we talked about that land acknowledgement with Treaty 6, and I always like to start with the aspect of, did you know that Treaty 6 had what they called the medicine chest clause? And when you look at the direct quotations from the text of Treaty number 6, And this comes from a wonderful article that was put out from Team Reconciliation, YEG. So they're a wonderful group to look up if you want more information that has to do with Treaty 6. Direct quotations from the text of Treaty Number 6, that a medicine chest shall be kept at the house of each Indian agent for the use and benefit of, and it's still in today's law that they will still say the word Indian at the direction of such agent. And for those who attended the last session, Selena explained that very well of why still today they use that in legal settings. So that's a direct quotation from the text of Treaty Number 6. Treaty 6 territory negotiated what is referred to as the Medicine Chest Clause, which in today's age is now usually interpreted as basic health care for First Nations within Treaty 6. Treaty 6 was the first to include the clauses, in general, which is pretty interesting too when you read up on that. And then also too, they had one that included a promise to protect Indigenous peoples from future famine and pestilence. So they were thinking very much, the future generations when it came to the signing of these treaties. That's why for me, I always find it's very important to acknowledge the treaties, because I always think they were thinking about us in that regard when they were signing it. They were actually thinking about us people who are here today in that regard. The future generations. So what's interesting is the Government of Canada's website attributes cutbacks to this clause for First Nations, as they have it written down as a deletion criteria. What happens is some prescriptions and medication become unavailable or they're not covered anymore. So as I say, while it's interpreted as basic healthcare for First Nations, there still is a lot of work Canada has to do to ensure that there's that health equity within Indigenous peoples across Turtle Island. What was interesting is Musqueam, which is a First Nations community that's just south of Edmonton here. There's actually 4 First Nation communities that make up Musqueam. They activated what was called the Medicine Chest Clause, what was mentioned in Treaty 6, in March 2020. And they declared a state of emergency due to COVID-19. So it shows even in today's age, going back to honoring the treaties, they still use those laws in a sense, or what was written in those agreements of those treaties, to ensure that the government does upheld, their end of providing the proper services to those communities. So this one's always very, very important to talk about, especially when we're talking about, like the discussion that we're having today, right? And to show that in Treaty 6 territory, where we're situated in right now, they have what's called the Medicine Chest Clause. And you might be now interested to go look into now other treaties and to see how it's written in each of those ones. But I always like to bring that local perspective in that regard. This is a little bit of a stat in that regard. Many Indigenous people live in rural and remote communities where it is difficult to access medical care. If we go up north, like 82% of Inuit in their traditional area, they do not have a family doctor. In comparison, for Canadians, it's just 1 in 5 in that regard. But with the Inuit population, it's 82% in that regard. Pre-existing health conditions in Indigenous populations increase risk of COVID-19 complications. And there also are relatively high levels of pre-existing conditions in the Indigenous population. And if this is kind of a chart that shows that from 2017. So, high blood pressure, diabetes, chronic bronchitis, and heart disease, those are things that are, as they say, they're existing health conditions that are within our communities many times. So when it talks about that aspect of, like even going back to the medicine chest of having just that basic health care, very important for us in our communities, because these are the conditions that many of us, especially when it says here aged over 50, These are conditions that many of us deal with in that case, or have family members that have it in that regard. So this one too comes from Stats Canada 2017. Some of you might be interested or might know what they call Jordan's principle in that regard. And what it was, or what it is, it's another way to ensure that First Nations children get the services they need when they need them. The lady that's been kind of the head of this one, really pushing the government to honor Jordan's principle, is Cindy Blackstock. And she's from the First Nation Caring Society, but it's also, they just type, like if you go on Google FN Caring Society, you'll find their website about Jordan's principle. So if any of you aren't aware of Jordan's principle, if this is your first time hearing about it, that's okay. Because this gives you an introduction kind of what is Jordan's principle, why does it even have the name Jordan's principle, and kind of the journey on it. It's still going into court today in that regard. So Jordan's principle is a legal rule named in the memory of Jordan River Anderson, a First Nations child from Norway House Cree Nation in Manitoba, born with complex medical needs. Jordan spent more than 2 years unnecessarily in a hospital waiting to leave, while the province of Manitoba and the federal government argued over who should pay for his at-home care. Care that would have been paid for immediately had Jordan not been First Nations. Jordan died in the hospital, sadly, at the age of 5 years old, never having spent a day in a family home. Sadly, payment disputes within and between federal and provincial government over services for First Nations children is not uncommon, and it's been happening for a long time. With the support of their community of Norway House Cree Nation and others, Jordan's family gifted his name to the creation of a child first principle to ensure First Nations children could get access so they could access the services they need without denial, delay, or disruption. Unfortunately, the federal government did not implement Jordan's principle as the family intended, and despite unanimous support in the House of Commons in 2007 for a broad definition, the federal government went on to implement, as I said, so narrow, a very watered down version of Jordan's principle, as they put it, in a manner so narrow that few, if any, First Nations qualify. So it does bring up an update in January 26, 2016. The Canadian Human Rights Tribunal ruled that Canada's definition of Jordan's principle was actually discriminatory and ordered the federal government to take immediate measures to implement the full and proper scope of Jordan's legacy. So there's a lot there to unpack there, as you can see. But as I said, it's still in the courts. They're still very much fighting for this ruling to come through its full fruition. But mentioning, someone like Cindy Blackstock, she's the one that's there day in and day out, urging the government that they have to do this. Like, they have to implement it in the full and proper scope of Jordan's legacy. So this is always one that's very important to talk about, because we just talked about the medicine chest clause and how, well, that is supposed to be interpreted as basic healthcare in that case. But we actually are still going into the courts, First Nations specifically, and other Indigenous nations too are going into the courts. But in this specific case, they are still going into the courts and fighting for just having basic access to healthcare in that regard. Because right now, as they put it, it's like jurisdictional ping pong a lot of times, which is terrible. Like it is really terrible. But as they put it, it's for services that are basic services in that sense that Canadians get, like clean drinking water, basic health care, access to education, all of those things. So what was interesting too is when you get to November 30th, 2020, there was an investigation in BC that found widespread racism and discrimination against Indigenous people, specifically in the healthcare system. So Racism, stereotyping, and discrimination against Indigenous peoples in the BC healthcare system are widespread and can be deadly, according to the findings in the independent investigative report. 84% of Indigenous peoples who participated reported experiencing some form of discrimination in healthcare. More than half of the Indigenous healthcare workers who participated said they had personally experienced racism themselves at work, providing that service. The report also sheds light on how current efforts in Indigenous or in education and training are inadequate, and why more Indigenous peoples are needed in health leadership and decision-making positions. So this investigation was led by former Judge Mary Ellen Turpel-Lafond, and she released the report titled In Plain Sight. And this was on that report, it was on the Monday of that year. So there's actually a really great APTN series they did. It was like I don't know if it was a 4-thing series, but it was on medical racism, and they had one with her on it. So if we can find it, she does a really great interview with Melissa Ridgen. So right now, that's kind of all I have. That was kind of just a preamp to kind of just give you, like Treaty 6, we have a medicine chest, there's Jordan's principle, absolutely. And then also too, that there are investigations that are currently happening that show that there is widespread racism and discrimination against Indigenous peoples in the healthcare system in that regard. So now it leads us to the wonderful Dr. Pam Roach, and she's going to be talking about all of this, and we're going to be learning so much more. So I'm going to stop sharing, and yeah, we can move to Dr. Pam.
Merci, Josh, thank you. First of all, I want to start out by saying that the honor is absolutely mine. I know we do follow each other on Twitter, and so I saw this email come through and I was very excited. And I always love the opportunity to talk with the community. I think sometimes working in a university, you sometimes end up kind of talking about the same concepts with the same people, and it's good to talk about this with people who are in the community and outside that as well, right? And try to make that impact in that way. And I thank you for welcoming me virtually into Treaty 6 territory. So I'm originally from a little Métis community. My mom comes from this community called St. Laurent on the shores of Lake Manitoba. So I was born in Winnipeg, and then lived for a short while out there, but have grown up mostly on Treaty 6 and Treaty 7 territory. So lived on Treaty 6 territory until I was a teenager. So it's nice to be able to come back in some capacities sometimes. And I just want to say as well that the bio is accurate, but it sounds really fancy. And ultimately, at the end of the day, I'm here as somebody who's trying to do that good work in a good way to make a difference and to improve things. And one of those really important things to talk about is just how these systems are set up and those structural pieces, right, of what this looks like and how do we shift it? How do we start changing it? What is our role in changing it? So I'll go ahead and get started, joining you from Treaty 7 territory. And I did also just quickly put in the chat, I think it was a really great summary of Jordan's principle. And we're lucky in a sense in Alberta that we have something here called the Alberta First Nations Health Consortium, and I put the link to their website, and they actually have advocates that you can call. So let's say you're a family at the Children's Hospital and you're trying to fill a prescription in the pharmacy and they're saying, no, you're not covered. And you kind of get into that ping pong. You can call these folks and actually get some help to advocate and make sure that your child, or if you're a healthcare provider, that if you see a child or a family struggling, you can get them what they need. And so they're really good at that. So I just wanted to point that out as well. I'll share a few thoughts maybe before we get started. We know when we talk about these things, we might feel uncomfortable. I want you to know that that's okay. That's normal. There's a difference between being uncomfortable and being unsafe. So it's important to think about how many people are unsafe in our healthcare system. So if it means that we all have to kind of sit here and feel uncomfortable for a little while, that's okay. And that's what we need to do. You can take a break. The advantage of online education and online webinars is that you can take a break. If you need to hit mute, you can hit mute and kind of turn me off for a minute. It can be an intimidating space to ask questions. I think you should be able to send a message to, it says like host and panelists. So if you'd like a question to be asked and don't want to put it out there, just send it that way. Or I think you can even ask anonymous questions. So lots of options there. And let's remember to ask things in a caring and compassionate way. Sometimes we challenge really deeply held beliefs when we talk about these things, and that's okay too. But let's just be respectful of everybody who's here and in this community today. And then the other advantage is, I have some slides here to talk about things, but the sense that I get from this group already is that it's much more of a community. It's not so much me being in front of you and doing a lecture. It's let's have a conversation, let's have a dialogue. And so if we end up going a bit of a different direction, that's okay. We can do that. We have the space for that. So really looking forward. I'm hoping not to take up too much time. Really looking forward to being able to have that conversation with everyone. And I just want to remind us why we're here. We know that medical education, the healthcare system, has a responsibility to Indigenous people from the TRC. And the TRC, as we know, was in response to a class action lawsuit around the residential school system. So I wanted to just ground us and remind us with the ongoing news that will continue for the foreseeable of the children who haven't found their way home. That's why we're here. And it's a very, I think, tangible reality now for maybe many Canadians who hadn't realized just what had happened, even though many of us have been saying for a long time, right, that there are many people who never returned home. There should be many more at our tables, in our kitchens, visiting, and just in all of our spaces. So I want to remember that. And I think I will also, if we're talking, we will be talking about the TRC today, the Truth and Reconciliation Commission report. So I'm going to start out by establishing a few truths. The first truth is that today we are taking the TRC as fact. It's not up for debate. Residential schools are fact. They were a tool of genocide. That's a fact. And those are things that in the context of our conversation, we can ask questions and we can have dialogue, we can challenge our assumptions, but we will not debate those truths today. And then the other truth is to know that our health systems are systemically racist and cause harm. And that might be, I know for some people who work within the health system, that might be challenging, right? And I think when we're talking about systemic racism, that's one of those things that isn't a personal affront to people, right? We can talk about the structures, and I'll explain that on the next slide. It doesn't mean that all the people within a system are racist. It means that even if in the absence of racist people, we have an inequitable structure. I did notice that someone just raised a hand. It said Peter raised his hand, and now I can't see what happens next. But if there's a way to ask a question, let me hit participants, that might help.
Yeah, Peter, if you can type it in the chat if you have a question, we can definitely. Dr. Pam said this is an open.
Absolutely.
Space. Oh, he said hit the wrong button. That's okay. Well, we're glad you're here, Peter.
All right, not a problem, but do feel free to interrupt. That's not a problem at all. I find just on that note around racism, it's good to establish some common language. And I think because we hear so much in the media, sometimes it's not always communicated clearly. So it's good to explain. Racism, this is from the National Collaborating Center on Aboriginal Health. And it's a good definition. It lays it out quite clearly for us that it's a belief or doctrine that there's inherent differences in human races that determine cultural or individual achievement, usually involving the idea that one's race is superior and has the right to rule others. And so we know that race is actually a social construct, but the way racism kind of presents itself is that it's biological. And so there's clear differences, which becomes a problem. And so there's different types of racism. The first one I want to explain is that relational or interpersonal racism. And those are those everyday experiences of behaviors that are discriminatory. And so once we know how to spot them, those are the ones that we usually feel confident in seeing. Those are, racial epithets, verbal slurs, graffiti, violence, exclusion. Those are the things that we can typically spot, and we can say that person is being racist. What is sometimes harder to spot, if you're not trained to do it, because it's part of our system and we've all grown up in the system and we're absolutely trained to not see it, is structural or systemic racism. And that's something, systemic racism is something we've been hearing a lot about in the media over the last year, 18 months especially. And I think sometimes it's portrayed as like this idea that there's lots and lots and lots and lots of racist things that happen within a system. And that might be true, but systemic racism is when you take out all of those things, all of those instances of very clear racial behavior or racist behavior, that the system, the structure that remains is still and inequitably advantages and disadvantages certain people based on race. And so Jordan's principle is a perfect example of that, right? That's not saying that anyone interacting with people may necessarily be being racist, but the way the structure is set up means that there's people at an advantage and people at a disadvantage. And the chronic underfunding of First Nation schools is also an example of that. And then the last one I want to mention about something that we call epistemic racism. And what I was going to say is that working in places like medicine or healthcare or the university, epistemic racism is very hard to see if you don't know what it is, but it's very important to understand. And so what epistemic racism is this really deeply held way of the Western knowledge systems dominating our ways of knowing. So it produces and promotes beliefs about racialized cultures as inferior to Western culture, and civilization becomes the obligation of the colonial group. So we see this in things like science and ethics, in simple things like the way we will name scientific concepts after mostly Western European descendant white male scientists, right? And so it's things like that, and not acknowledging that things existed and ways of knowing existed that predated those people. One of the examples I use from a local to me is up in the mountains. One of the most popular hiking trails is up to some lakes called Grassy Lakes, and they're named after this person whose last name was Grassy, who came to Canada and loved the mountains and was really sort of quite critical to preserving different parts of the mountains, but then named these lakes. And, you know, I think there's like a sign or something that says like they were discovered. And I was like, I was up there with my family and I said, well, they weren't discovered. They were always there, right? And so that's just a small example of the way those kinds of ideas actually just completely are pervasive within what we do. So how does racism play out in the healthcare system? Well, we talk about public health emergencies. We talk about pandemics. This is a sign that was used by protesters recently during the latest resurgence of the Black Lives Matter movement, that racism is a pandemic, and it's certainly a public health emergency. And we can see that the Canadian Public Health Association, even back in 2018, declared racism a public health issue and that we needed to speak out about it. It is structural and policy driven, right? So Dr. Abraham Kendi, if you're familiar with his work, he's become the awareness of his work has become much more popular in recent times as well, but really talks about racism as a policy issue. So if we're going to address those structural concepts, we really need to be thinking at those big systemic issues. So we do need those kinds of solutions, right? We need structural ways to address it. The Public Health Agency of Canada isn't the only policy organization that's spoken out. The CDC has joined hundreds of cities and countries across the United States declaring racism as a public health threat, right? So in April earlier this year, the director called racism an epidemic that affects the entire health of our nation. We've seen these large-scale responses. But what does it mean? Well, even on the smaller scales, we can see the American Public Health Association. These are, you can see like all the little yellow bits or orange bits are places, those are local municipalities that have also declared racism as a public health emergency. So as we have more of our agencies that are directing policy, that are directing work and improvements, declaring racism as a threat to the health of people in general, we can hopefully start to see more action supported in different ways. And so talking about those things around education, and I think someone put it in the chat at the start, right? That there's not always a lot of progress that gets made when we talk about cultural competency education or cultural awareness education. And because we can do those things, but we don't know how much it's going to drive behavior change. And so that's kind of the stuff that I spend my time looking at. And why it plays out and how it plays out within the Canadian healthcare system is really important. We can look at this graph. So this is the First Nations Health Authority, the Alberta First Nations Information Governance Center. Sorry, they publish one-pagers of lots of different health indicators for First Nations people within the province of Alberta. And so that you can go and you can look at their website. There's a link there. You can Google them and you can go look at all of those kinds of chronic conditions that Josh introduced us to as well, right? So there you can look at the trends for diabetes, for cardiac conditions, for high blood pressure. You can go and look at those things and look at what the actual data says that's held by First Nations information governance. So they hold on to the data, they control the data, and they control how it's used. But on this one, we can actually look that in 1999, the life expectancy gap between First Nations people and non-First Nations people living in Alberta was 7.3 years. And then in 2015, it had widened to just under 12 years, 11.9 years. So that's controlling for other risks, that's controlling for other indicators. And I think what is really important to highlight there is that's despite all of the work that we're doing, despite all of the work the people in the healthcare system are doing, despite all of the things that we're trying to improve, the gap continues to widen. So we really need to see that as a driver and an indicator for just how important this is, that we keep doing this and we figure out the structures and the systems that we need to change. You know, when I do talks like this, I often put together a slide. Sorry, you'll see me kind of moving towards my screen because it's the time of the afternoon where the sun comes through the window. And so I'm just gonna have to move around a little. But when I do these talks, I put together slides usually that have screenshots of things that have happened in the headlines, right? What's made it to the news, knowing that not every story makes it to the news. Not every story gets reported. And every time I do a talk, there's more headlines to include. So we do have, towards the bottom left, you can see BC hospital staff accused of betting on blood alcohol levels, that Price is Right game that prompted the In Plain Sight report. We can look at, I felt robbed, an Indigenous mother says baby's apprehension was wrong, and that was in Kamloops. And I think 2019, she had her first baby apprehended, and then 2020, she had her second baby apprehended at, you know, a few hours after birth, because the accusation was that she wasn't taking it seriously. She wasn't awake enough to care for her baby, and therefore social services was called and her baby was apprehended. She had a C-section and she was still on like recovering from the anesthetic, but it was used as a way to take those children into social services, right? There's lots of other stories. There was another story that came out from Quebec after we heard about what happened to Joyce Echaquan, who I will speak about in a moment. There's all of the accounts of forced sterilization. And when we talk about structures and systems, there's an example that's tragic and really illustrative of that, in that there used to be midwifery funding. There was midwifery funding for a time in the north, so that women, so this woman who was in Nunavut, they didn't have to be sort of air-vac'd or medevaced out of their community to have babies. They had midwifery services, and then the funding to that was federal funding, and it was cut. That program was cut. So then there was no midwifery service, there was no birthing services in the north. A woman had to, in January this year, was moved to Winnipeg to have her baby, while in the hospital in Winnipeg contracted COVID and died. So then that newborn baby and the rest of her children and family at home were then left without her. So that's an example of how these systemic decisions have very real individual level impact to people and to families and communities, right? That woman is now not there for her community. And then some of the most high profile and really important stories that we have heard about. In 2008, Brian Sinclair went to an emergency room in Winnipeg with a blocked catheter and a bladder infection. He had a note from his doctor in his pocket, and he went into the emergency room to seek treatment and was ignored in the waiting room. He was left there for over 34 hours on his own. Other patients tried to advocate for him, tried to tell security. Security told the desk, and nobody checked on him. And there was an assumption that he was there and he was drunk because he was Indigenous, and that he was sleeping it off in the emergency room, and was ignored to death, essentially. And then in just around a year ago, Joyce âpahkowâyânaw died in a hospital in Quebec. She was 37. She has 7 children. And it makes me reflect on the fact she's younger than me. She has children, I have children, right? And she was in pain and she was ignored. And it was the inquest into what happened just happened this spring. And there, I didn't feel there was a lot of remorse on the part of the people who were involved. And again, this is an instance where other patients were trying to advocate for her, and even that didn't make a difference. And Joyce, in her last moments, was enduring racist abuse from the nursing staff, and actually had the presence of mind to record it and live stream it on her Facebook. And so I think it's hard to watch, but it's important she did that, and we bear witness to that, because that's the story that made it. And there'll be lots of stories that haven't made it. So for everyone that we hear about, there's a lot more that we don't hear about. And when we talk about those things, especially when we talk about emergency room experiences, there's some work that's coming out of Alberta around First Nations emergency care in Alberta, and discussing what are those experiences of people. And really what we're seeing is that there's a delay in going to the emergency room. Indigenous patients are worried not only about the treatment they're going to receive, because they are anticipating racist encounters, but also, if they have kids, and if they are talking to the doctor or the nurse and they say, well, I had to leave my kids at home to come to the emergency room, does that flag them then for a social services visit? There's also evidence within this work here. There's a number of papers that have come out that talk about that Indigenous people, particularly First Nations people, are triaged at a lower acuity. And what that means is that they could be in the emergency department with the same condition as a non-Indigenous person, and the person who scores how urgent they are to be seen will score them lower than a non-Indigenous person. And actually they die of treatable conditions much more frequently than non-Indigenous people. So those are systemic issues, right? That's how people are being trained to work within the system, leading to really, really clear harms. So how did we get here, right? Like that's the thing to talk about. How did we get here, and what do we do about it? So let's start with the how did we get here. I've taken this photo of a figure from the UN Declaration on Rights of Indigenous People. And this is sort of a companion document around rights, healthcare rights, and access to healthcare of Indigenous people around the world. And it talks about social determinants of health. And so what we talk about there around social determinants of health are things, you'll typically see them as things like education, access to food, all of those kinds of things. And really, when we look at social determinants of health for Indigenous people, that first thing on your left-hand side of colonization becomes really important. And a lot of my work, I can give you an example, a lot of my work is in dementia care. And we see higher rates of early onset dementia in Indigenous populations, particularly in countries that have experienced colonization. So Canada, the United States, Australia, New Zealand. And we see that when all of those other risk factors are controlled for. So all of those other reasons that we think might explain it, we control for those, and we still see it. And so there's a lot of intergenerational health impact because of colonization and the restrictions that were placed on people and the way it disrupted connection to culture and connection to healthy ways of living. Will we discuss, I've got a question, will we discuss consent as well? Like consent to medical procedures, we can absolutely talk about that. That's a huge issue as far as the forced and coerced sterilization. There's a case going on, or something that's being investigated right now, and I think, don't know if Josh also follows this person on Twitter, but there's an Indigenous lawyer in BC, Breen Wiet, and he exposed the fact, he didn't obviously offer any details, but he exposed the fact that Indigenous people were contacting him because their children who were in foster care and in the child welfare system were being fitted forcibly with IUDs under the age of 10 to prevent pregnancy in foster homes. And so when we think about that example, and I'm sorry, I know that that's very triggering, we think of the system that's involved there. So not only do we have the social services system putting children into unsafe foster homes, they're now performing medical procedures on them against their will, without their family's consent, without their community being there. And as a solution, rather than finding them a safe place, returning them to their family, returning them to their community, or finding them a safer foster home, the solution to sexual abuse of Indigenous children is to fit them with IUDs, right? And then we think, well, who's taking part in that? So not only there may be a lawyer, there may be an advocate, there'll be social services, and there'll be physicians, right, that are involved in that. So that's sort of those things that are happening where consent is absolutely taken away from people, and that coercion. And nurses, yeah, absolutely. And so there's no way, there's, sometimes we're like, defund this and defund, we'll have more social workers. More social workers aren't always the answer. It's a systemic structural issue that we need to address across all of our structures, because they all intersect and they all contribute to the harms that are perpetuated, and absolutely not taking consent is definitely one of those. So I hope that answers. We'll have more time for discussion if we want to talk about that a little bit later too. Okay, so colonization, and I was very pleased that you heard about the Indian Act last time. So that's a huge piece of the puzzle when we look at how Indigenous health is played out today. And the Indian Act really restricted people's ability to take part in society. And it had a lot of rules. It also led to the creation of Indian hospitals, and the Indian hospitals and the residential school system essentially fed into each other at the benefit of the colonizing society, right? And there was a lot of harms that are still being dealt with today. As part of the Indian Act, we know that residential schools were instituted. Children were mandated to go to them. I've put a link here. This is for the National Center for Truth and Reconciliation. And what I would do is, for anybody who maybe hasn't engaged in learning a lot about residential schools, or maybe it hadn't really been on your mind until the news this year, I would encourage you to engage with this website. You can look at what schools are near to where you live. You can look at what schools are near to where you grew up. Maybe you grew up somewhere else. You can look at the pictures of the children who went there, and you can read the reports of the things that happened there. So I would encourage everybody to maybe look at that, engage with that, start realizing, these things were around us. And when we look at Alberta, we have the highest number of residential schools of any jurisdiction in the country. So the reason that this becomes really important is that there's a lot of lasting health impacts. And when we look at the TRC has 7 health-related calls to action. And that first one, number 18, is asking all of us to acknowledge that the current state of Indigenous health in Canada is a direct result of previous Canadian government policies, including residential schools. And I would argue it's also current Canadian government policies, right? And so all of these things there's a lot of Indigenous health impacts that we see today that are absolutely related. I would encourage everybody again to go engage with the calls to action. If you work in healthcare, read the 7 health-related calls to action. If you work in education, read the education calls to action. If you play sports, read the sports-related calls to action. There is a way for you to engage and find your role in reconciliation, but just go through it. You can actually go onto the website. You can order these little, I'll hold it up. Sorry, it's so bright, but these little orange booklets that are like pocket-sized, and you can keep the calls to action in your pocket and look at them and refer to them. So I would just encourage everybody to do that. And then we look at some of the calls to action, and they include, resolving jurisdictional disputes, like what happened to Jordan Anderson. It tells us to provide sustainable funding, right, for Indigenous-led healing centers. It calls those of us who can affect change to do it, right? To not get caught up in the red tape and the infrastructure and the policies and the hierarchy, but just to do it, make the change, look around you, figure out what changes are in your scope of practice and your capacity to do. And then also to start incorporating anti-racism and education around the United Nations Declaration on the Rights of Indigenous Peoples, the treaties, Indigenous rights, the Confederation, the Indian Act, and anti-racism, all of those things within our healthcare professional education and training. So then I think it's important that leads us to this idea of breaking the cycle. So this diagram is from that In Plain Sight report that came out of BC. And this talks us through colonization, how that impacts the healthcare system, and then how do we get out of this? This is where we are. We're in this system that was designed to exclude us. It was literally designed to harm us. So how do we stop it? And thus we actually have to integrate Indigenous systems, knowledge, ways of knowing, practices, and they need to be done equitably, and they need to be done structurally. So as we heard at the beginning in the opening, that idea that it's not good enough just to have the education and training, but we need people in leadership, we need people with decision-making power, and we need to maybe rethink power structures, right? Like a hierarchy that's a triangle, the more, just because you put different people at the top of the triangle doesn't mean that those people at the bottom are treated any better, right? So we need to rethink that. We need to rethink that hierarchy, and we can flatten that. We can have more of an equitable, community-based approach that's less about power over others and more about keeping everybody well, right? If we want to all be well, we need to all be well. And if we take that approach, we'll hopefully make some progress. Canadian context. I just also wanted to introduce, when we think about that diagram that came from the In Plain Sight report, there was 24 recommendations that came out of that report. And as you heard, those experiences in that report would be very similar if we looked at that anywhere else in Canada, right? Those are systemic things that happen in all of our systems. All of these things call for us to align with UNDRIP, with the United Nations Declaration, to implement anti-racism. The Reclaiming Power in Place, which was the Murdered and Missing Indigenous Women and Girls report that came out in 2019, had 231 calls to justice that are very similar to the TRC calls to action, that are very similar to the 24 recommendations from the In Plain Sight report, that we need Indigenous-led healing services that are trauma-informed, that we need training for Indigenous healthcare providers, right? If we want to have more people in those decision-making positions, we need more people in the system, but our system also has to be safe. We can't just keep including people in a harmful system. So we need more people, we need a better system, we need better education in Indigenous health and anti-racism. And then that really aligns to this idea of self-determination, right? And what really struck me at the beginning when we were talking about that medicine chest clause in the Treaty 6, in the treaty, that the medicines were still to be used at the direction of the Indian agent, right? And so it was still the Indian agent who gets to choose how that's used. And if we think about what that looks like now, then it's still, the system, it's still the federal government, the provincial government, whichever health system you're accessing, because there are sort of parallel systems, that it's not Indigenous people in most instances who are directing how that is to be used. So when we look at the United Nations Declaration on the Rights of Indigenous People, self-determination is a key component of that. And when I often think and I reflect about how do we create change, we do need self-determination. We need self-directed, Indigenous-led health services that are, grounded in community, that are guided by community. What does community need? How do we make those changes happen? And so that's why a lot of the health research is always in partnership with communities to be driven by their priorities and finding a way to make that work, because the systems as they stand largely don't do that. And there's a few instances here and there where they do, but for many people, they are accessing a system as directed by someone else, right? And not as directed by themselves. So think about that self-determination. I'm not going to include like lots of like data and papers right now, but there is research that shows that the presence of self-governance and self-determination has a positive impact on Indigenous health, right? When we think of those social determinants of health that I mentioned earlier, self-determination, self-governance, the ability for communities to decide for themselves, is actually linked in the evidence to good health outcomes. And you're saying right now, well, that's great. You've told me everything that you've told me that the problems are, you've told me how we see it play out and how we got here, but what do I do? And so, I think that's something we all have to figure out for ourselves. For me, I try to work to find solutions to the places I can within the health system. I try to be directed as to what to do. I try to do talks like this to reach people and start conversations, and maybe a few people today decide, I can make some decisions where I work or live for the people I'm around. I can start having these conversations. I can reflect about what my life is like and where I could make a difference. So to give you some tools, these are a few statements. This is based on a paper that came out in the 80s, and it was actually based on women's studies and gender equity, but it's very applicable, and it gives you a series of statements to reflect on. And this is by a woman named Peggy McIntosh, and she thought of it as a backpack. If you think about it, you have a pretend backpack, and within your backpack, you have different kinds of what we would call privilege, right? And I think sometimes that's a difficult concept for people to think about. They think, I've worked really hard. I wasn't given anything, but let's like pick a few of these thoughts and just reflect on them. So if you're thinking about what's in your backpack, and what's in your backpack may change from time to time, and it'll certainly be different for all of us, but it's things like, I can, if I wish, arrange to be in the company of people of my race most of the time. If I should need to move, I can be pretty sure of renting or purchasing a house in an area where I can afford it and where I would want to live. And this is a big one for me when I think about many, many things. When I am told about our national heritage or about civilization, I am shown that people of my color made it what it is. And how many Indigenous people really feel that when we talk about the way we talk about society? I could tell you the number of times I've heard people say Canada is a country of immigrants, which it is. There's, lots of people from lots of different places, but my son was in a room and was told, well, we're all immigrants. And he was like, wait, but we're not, right? Not everybody is. And then that erases the contributions that Indigenous people have made to our current society, right? We're not relics of the past who don't exist. We're here and we contribute. I can be pretty sure of having my voice heard in a group in which I'm the only member of my race. I do not have to educate my children to be aware of systemic racism for their own daily physical protection. If a traffic cop pulls me over, I can be sure I haven't been singled out because of my race, right? And so thinking about that, that's a different situation for different people. So all of those things, I just encourage you to think about it, to think about them, think about those ones that you have that other people might not. And then how does that change what you do? lastly, this is sort of more about interpersonal racism, but it's always handy and I like sending it out. It's open source. Copy that little website address, look it up. You can cut it out and fold it. And then it's like a handy little anti-racism pocket guide. But this is good if you think about it as a healthcare provider, or next time you're in a clinic or in a hospital and you feel that somebody's not being treated justly. Do you feel comfortable speaking out? And sometimes you need a little bit of help, right? Sometimes you just don't have the words. And so these are things that can give you the words. So sometimes people might say something and you'll be like, oh, I'm not sure I understood you. Can you explain? And then someone either has to really think about what they're saying or try to explain it. But it might disrupt what's happening enough that you can advocate for somebody in that way. Or you could say, I feel obligated as a peer, as a friend, to tell you this. And sometimes that happens. Sometimes people will use language and be like, I think I just need to share with you that that's not really how we talk about things these days, and opening those conversations. And that's, the ability to advocate, the ability to interrupt these situations will vary person to person, time to time, depending on the circumstances. But this is helpful in a way that it sometimes gives you that language, and gives you something that you can literally keep in your pocket. So pick one and try it out. And when you're comfortable with it, pick a second one and then try that one out, right? These are just some more along the same lines, just different ways to say, oh, I disagree with you, right? Or, ooh, that didn't sound right. So just some different ways. And then, what can you do to make this change happen? There's lots of different ways, and there's lots of different resources. A recent resource that came out from the Canadian Medical Association is called the Unforgotten. It's a video, it's a 30-minute video, or you can watch it in 6 sort of 5-minute pieces. And there's reflection questions you can look at. But it's about, if you've not started, if you're wanting to sort of engage in this journey and find your role in fixing some of the structural changes that we see, that we need, and that we see that are needed, is starting to reflect on that and where you can make change happen. And that's one thing I always emphasize, is that we're not all in these decision-making positions, but we all take up space in the world in some way. So there's things that you can do. There's ways that you can start learning about these things like epistemic racism and systemic racism, and figure out how to see it around you. And once you start seeing it, you're not going to be able to unsee it. And then you're not going to be able to just sit and watch and not do anything about it. So I encourage you to start trying to see it, and then continue the conversation. That's part of what all of this is about, is having these conversations, finding this common language, and finding a common way forward. So I hope that's been meaningful to some of you, all of you, and maybe I'll stop sharing my screen and then we can have a bit of a conversation. That would be nice.
Well, I thought that was wonderful. That was a really wonderful presentation, and there's a lot that I learned from that, even myself. And I agree. Yeah, we should totally open it up for any conversations. If anyone wants to ask any questions, I see Madison, you raised a hand. You can absolutely, yeah, answer questions for sure.
Yeah. Madison, I see your
says I can, let me see. Did you want to try to talk, Madison? It says I can allow to talk. I'm going to click it and see what happens. Tanche, Madison. There, or
oh, we can't hear you.
yeah, I don't know. It wasn't.
It looks like Madison put the question in the Q&A.
Okay.
Okay, perfect.
And she's asking, is there a resource for that impact statement of children in foster care history?
So I think that's a pretty new, so do you mean the with the IUDs? If that's the one that you're referring to, I think that's an ongoing current situation at the moment. That I think.
Sorry. Yes, that's probably the only new topic to me.
Okay.
And I was just wondering if it can be referenced anywhere, as I do follow a lot of things that are happening.
Yeah, I think it's pretty new. And I think because it's current and ongoing, and I believe that there's probably some legal involvement that all I know is what's been shared publicly, which isn't a lot. So I suspect we'll have to wait for more information about that. And I would like to acknowledge that also somebody put in the Q&A that they've been, they're feeling upset and currently are unable to engage because they're crying. And I want to acknowledge that because.
So I'm sorry, that was me saying I have a crying child.
Oh.
And yes. Sorry.
That's okay. You know what? Crying children, absolutely welcome. I sometimes have children running around or a puppy running around. But I do also want to acknowledge that it is sensitive material. It's triggering, and I understand that. And so I think if anybody needs to, take a break or wants to get in touch after, my email is publicly available. There's lots of conversations that we need to have around these topics. So please, let's not have this be the end of the conversation. And the more you reflect, the more you might need different people to talk to.
Yeah, and that's always a good point. I always make sure to share that with folks that, this is a safe space. And a lot of times, what's shared stays in the circle in that regard. Of course, though, this session is recorded at the same time, but just letting you know that, yeah, if you're feeling any kind of emotions, don't hesitate to reach out to anyone that you trust. And also too, you can absolutely reach out to me or Dr. Pam if you have any more questions when it comes to this kind of topic, because you might have some that comes like a week later in that case. But if anyone has any more questions, absolutely. We still got quite a bit of time here. So Alan, do you want to try to talk, Alan? I can get you on the here. I got you up here, Alan.
Hello, can you hear me?
Yes.
Okay, thank you for taking my question. So I have a struggle. I'm a white guy, and I fully appreciate and am grateful for the privilege that I have as being a white guy. So I get that. I just want to understand better what role and how I might be supportive to my Indigenous brothers and sisters and not be intrusive. Like, oh, here's another white guy who says he's going to solve my problems. Like, nobody wants to hear that. I get that. So, and I'm not, I struggle with what role I can play and how I can be helpful, but not harmful, or not what would you say it? Not perpetuating racist beliefs, not perpetuating that my Indigenous brothers and sisters are somehow less than, and I need to step in because I know that's not true. So how do I move forward?
That's a great question, Alan, and thank you for asking it. It's an important one, and I think it's a little bit different for everyone. I would say, so what you're alluding to, I think, is something that we call in like the fancy language, like white saviorism, right? Like people are gonna come and fix everything. And I often, and sometimes that's what brings people to the desire to want to improve things. But it's that recognizing that I have plenty of non-Indigenous friends and colleagues who do wonderful work, who are engaged, who are good allies or accomplices or whatever we were going to call them. And it's that idea of leading, making sure that Indigenous people are leading and guiding and directing whatever the work is. And I use work not necessarily in a work like employment kind of sense, but whatever the good work is that we're doing, that Indigenous people are leading it, and their voices are the ones that are determining what's to be done. And then you can say, what do you need me to do? What is my role? And maybe sometimes that role, sometimes when I do teaching around this kind of material, I'll have a non-Indigenous colleague with me if I know it's going to be a largely non-Indigenous audience, because sometimes I need that person to be the person that the audience will identify with, who can interrupt them and say, whoa, that's a bit out of order, that's uncalled for, and sort of taking the heat off of Indigenous people, allowing them to just do the work and thrive. And so sometimes it's playing that role. Sometimes it might be a different role, but always making sure you're led by what Indigenous people are telling you.
Thank you for that, Dr. Roach. Can you add just one thing? You had said about a non-Indigenous allies that you have. You have many. Give me an example of one, like just paint a picture for me so I understand that I got something to aspire to. Let me know. Tell me about one.
Yeah, so many examples, but sometimes it's even if somebody, let's say somebody asks you, let's say you're involved in you're like really deeply engaged in reconciliation and those kinds of things. And sometimes people get invited, let's say, to do a talk like this, right? Or even just, hey, like, can you come talk to our little group about things that you've learned? So instead of you taking that space and taking that role, you might say, well, you know what, I could, well, why don't I ask, and let's find a way to maybe compensate people for their time, but why don't I ask someone from an Indigenous community who I know, who I have a relationship with, right? Do you have a solid relationship, an authentic relationship with that person? And let's have a conversation and find a way to do that in a good way. So then maybe you become the person who makes sure that everybody else knows that they have to create like a respectful, ethical, safe space for that conversation. But you don't take that platform yourself, right? You give that platform to someone else. Does that make sense?
I think I understand it. Thank you so much. I'm with this other group that I hang out with called Call to Men. And they always talk about elevating voices that need to be elevated, right? And they always go to the margins of the margins, right? And so I get it. Thank you. Makes sense.
Marce, Alan. Marce.
So we have a few questions. This is great. I'll work my way down, I guess.
Yeah, absolutely.
Are there Indigenous-led hospitals in Canada or places folks can access care in a more safe way? I can give you a few examples for sure. Like locally, some of the First Nations have their own health authorities and health centers. So Siksika, which is a Blackfoot community to the southeast of Calgary, have a health center, and they actually do a lot of work in Calgary as well. And they were involved in setting up COVID vaccination clinics. The Métis Nation had vaccine clinics. I got my second dose through a Métis clinic here in Calgary, which was nice to be able to do that. So there are examples like that. For virtual care, there's an Alberta Indigenous virtual care clinic. So if you need to talk to a doctor, you don't have a family doctor, or like you can't see your family doctor and you're Indigenous, there's a virtual care clinic you can call. And there's a lot of Indigenous people involved in that clinic as well. So there are definitely examples. In BC, there's the First Nations Health Authority. So there's definitely examples. I think we need more of that, right? And in Calgary, we have Elbow River Healing Lodge, which is an Indigenous community clinic, which has like a room for sweats and ceremony and all those things built into the building. So yeah, there are a few really great examples out there that we can definitely keep learning from. Another question, can you offer some advice for educating family members who may have knee-jerk reactions to Indigenous issues? Often the reactions are rooted in harmful stereotypes. So I do. So I think sometimes those little resources I put at the end of the slides, sometimes those things are helpful. It's tricky with family, I think, because with a stranger, or with someone at work, or someone we meet somewhere else, or a friend, maybe we're more beholden to social norms and expectations, whereas family, we will, I don't know, I think there's more capacity for people to have arguments and things. Most families. So it can be trickier, but there's definitely ways that you can do it, and you can start by just talking about it. And if someone disagrees with you or has a knee-jerk reaction, say, oh, well, I actually learned this really interesting thing, and explain it. There is a good website, I think it's called Anti-Racism Every Day, or Everyday Anti-Racism. And it's written by a woman who lives in New York, who's a white ally. And she really started doing it in response to Black Lives Matter. It's fairly applicable for most instances where you're encountering racism. And she actually has guides for, like, okay, you're going home for family dinner, like Thanksgiving dinner, and you know that you're going to have racist relatives there. And it's almost like graphic novel, cartoon type guides to having these conversations. So that's something that I can find the link for, but it's something like that. And you should be able to find it pretty easily. And there's guides for youth and all kinds of things. Okay. Madison, I'm sorry if I seem unsensitive around it. From my sociological view of that, it seems all too complacent that the systems keep these types of things happening. And now to this level of irresponsibility for cashing checks. So there's some of the ways the systems work are so ingrained in just the structures, it's hard to undo it. And that's why I think some of the big changes are going to be messy, and they're not going to be easy, right? And a lot of people are going to be unsettled by the changes that need to happen, and we see that. And I think that's another thing that we talk about. You'll hear things around like the fancy word is white fragility or settler fragility, and that's this idea that talking about these things, that making things equitable for everybody could cause people who have always kind of been advantaged in the system to lose that advantage. And that's why they push back against it. I have someone that I work with at the university who I consider a great mentor, and he always reminds me that a rising tide raises all boats. And so it's that idea of, if we increase equity for the groups that need it, we actually increase equity for everybody. It's just that those people maybe who have never had to think about these things are scared that it means they might lose something, right? But I really, really appreciate everybody engaging in the conversation, and thank you. I see lots of Indigenous people in my capacity as a healthcare provider. How can I demonstrate that I am an ally? So there's so many different ways of doing this. I think within the medical school, I work with Dr. Lindsay Croshoe, and he's developed a whole teaching sort of system around helping us educate healthcare providers to act in more relational ways, right? And to ask people what they need. So I think part of it is just relating to people as people, and trying to understand their social world. As far as those little indications, I often think about ways we signal to other people that we're allies, right? So I have like a little pronoun badge that I can put on my lanyard when I'm at work. And so that's a signal to people who are of diverse genders that I'm an ally, right? Like I'm gonna put this out there, and you don't have to tell me your pronouns, but these are mine, so that you know that I'm an ally. Or I might have like a rainbow badge, or I might have I have a little, like the rainbow and the trans flag thing that I can put on my lanyard as visible signals. I do have some physician colleagues who have orange shirt pins that they put on their badges, just as a visible signal that they are trying to be an ally and to understand. So I don't know if that's super helpful. And I'm talking a lot, so like, if people want to, I'm trying to look at the chat as well.
You're the expert, Dr. Pam. So I'm just very grateful.
We're all experts. I'm the expert in like fancy language, right? Like I'm not an expert. There's so many.
Okay, what was the
questions.
last one you left off at? It was the going. There was someone
Yeah.
asking. It was anonymous about a resource video. This video itself is going to be recorded and available for people to watch after. So this one itself, you can absolutely use. But maybe Dr. Pam would know about other kind of like resource videos that, as they literally worded it, to help educate Canadians on. Well, they just say on racism in Canada in general. So I'm sure there's actually, yeah, there's probably a wide range of videos that you know, absolutely out there.
There's a great one that you can find on YouTube called The Gardener's Tale, I think. So there's someone in the United States, Dr. Pamela Jones. She's a Black academic, and she's done a ton of work on racism. And so if you look up Pamela Jones, I'll put it in the chat, and then I'll take a look at the chat questions. Pamela Jones, levels of racism, Gardener's Tale. There's a great little 5-minute video about flowers. That's a really easy to understand way to think about racism. I just want to acknowledge some of the comments in the chat around consent. And so CH said, I know Ottawa Hospital is discussing changing to consent to involve community for Indigenous patients. That's really interesting. New way of thinking about it, right? And how do you determine if people are understanding what you've told them? And I think that's definitely a problem, particularly with COVID, when we might have limited sort of family members or visitors or helpers in the hospital. Someone says, thanks for the resources. Okay, one suggestion could be to stand up to people in our close family and friends circle. Being a non-Indigenous person, I have tried taking that approach. It's hard, but yeah, sometimes you have to say, and sometimes it's really helpful. Like I find sometimes if I'm in a group of people and someone says something a bit problematic, to have one of my non-Indigenous friends respond to it. It's like one less time I have to respond to it, which is nice. Peter says, I find conversations with what I think the average Canadian very difficult. Yeah. So that's a great statement. Let's see. Yeah, and other comments include, is there resources, Moocs? And so I think there's lots of resources. There's another one I think I'm going to point out, which is the Indigenous Canada Mooc, which is Mooc, it means massive online open course. So through University of Alberta, they have one called Indigenous Canada. It's a 12-week course. You can pay, I think it's around $65 for a certificate of completion if you want that, but you don't have to. It's otherwise free to access, and it's really great, right? It's a really great way to introduce you to a whole host of topics that maybe you haven't been exposed to before, and also that idea that people are not always engaged. They don't recognize racism, and I guess as a reminder, like we're all socialized to uphold the status quo, right? So sometimes for people, it creates this really hard shift in the way they see things. And some people really resist that for a long time and maybe forever, but sometimes people can move past it. And so it's that idea of creating that shift and then supporting people through it, which can be difficult, but that's maybe another role for those non-Indigenous allies, right? I also said, I've heard comments about how the blanket exercise is triggering for Indigenous people at the expense of learning from white folks. So it's not a good learning event, but have attended, I've attended a blanket exercise. I did find it very emotional. But I think there was some people, it was actually at a particular work site that I'm sometimes on. And because there was people there who knew me, I actually think it made it more transformative for them, because I think they were like, oh, wow, there's actually like, I work with Indigenous people, like there's Indigenous people all around me. But I think that's, the people who facilitate those blanket exercises are trained to facilitate them, but I would caution, like it can be very emotional for Indigenous people. I think for non-Indigenous people, it can be a good learning tool.
Yeah, I can speak on that too a little bit, just because I facilitate blanket exercises in the St. Albert area. And that for me, I always try to make sure that it's one that is facilitated by Indigenous peoples or Indigenous peoples. They have an elder involved, or at least some of the facilitators there are Indigenous. In our community, we worked quite hard, and even Wendy, who is in, I don't know if she's in the session here, but she can kind of speak to that too. But working to create a really localized kind of blanket exercise script for our specific areas in that regard, to include the local knowledge and history in that regard. But with our case, with my group specifically, we always make sure that's people who are facilitating these exercise. They come from the lived history too. In that case, because of what you just said in that chat, where it says it can absolutely trigger emotions for us. I mean, even for me, when I would go to a session, I got to play a role of a European or something like that. You know what I mean? Because that's how those exercises go. Absolutely. But it is a really great. I do think it is a great learning tool, especially for people taking that first step. And as I said, where I work at, and even because I know the great work that Wendy Goulet does in this chat here up in Peace River. There are communities that are making sure that we're the ones that are teaching the history in that sense. We're just using that formula that has been put out there. So yeah, it's definitely interesting, but I think it's absolutely it's a good tool for sure. But as I say, for me, I always make sure it's facilitated by folks, like if they have an elder involved or folks who are Indigenous. And Dr. Pam brought up a really great point, where I've gone to plenty of ones where they realize that they have coworkers that are Indigenous, like they worked with each other for like years in that case, and they're finally just realizing that they actually work with other Indigenous people. So it's a really cool kind of conversation starter too, if you do it in a work setting too, in that sense, with a lot of people who know each other. But that's a great question though you asked, for sure. Because like even for me, like as I say, I wouldn't go to every single one, but if there was one that says, oh, there's this facilitator and this elder and this, like, once again, I'm not trying to keep putting Wendy on there, but if Wendy was facilitating one and I saw her name and other, I'd be like, perfect, that's one I would absolutely go to 100%. So yeah.
And I'll just point out too that it looks like someone put in the chat the link to the Anti-Racism Everyday website. Thank you for finding that and putting that in there for everyone. So that's a helpful tool as well. And then I think there was a last, and the Accidental Courtesy by Daryl Davis has also been recommended. And just a last note, there was some conversation in the chat around diversity training and does it work, right? And I think, it depends, I guess, there's not an easy answer. It depends on who's in the room, who's there, what environment are they in, are they being supported? But I find that it's not a quick learning objective to achieve, right? So it's generally, you can start learning about it, but there really needs to be some ongoing learning on the part of the person, but then some support as well to be able to keep having these conversations. So that's what my goal always is. Let's keep having these conversations, because now you're going to go out to your lives and you might encounter a situation and think, oh, did I handle that the right way? Or I'm seeing this thing, this system in front of me, what do I do next? Or could I have done it differently? And so it's helpful to have people to talk about those kinds of things with. So wherever you are, I hope that you can maybe start to find a community of people to be able to talk about that and have those conversations with.
Yeah, no, and I mean, I've done some diversity training myself, like actually going into organizations, and even one in certain healthcare systems here in Edmonton. I won't name specific stuff, right? Especially right now with what's going on with like, we have to support our HS workers right now in that regard with everything. But as you said, it does literally depend a lot of times on who's in the room. Are they committed from the start? Are they just bringing in people for a check mark in that regard? And it can't even be if like they have one, like the person who organized it, they're on board, but if none of the staff are on board, it's very tough to go in and do those training exercises with those people, because like my experience was, and this was well before I was with CFRAC, but it was like people were telling me, like, when I go up, you go up and share your perspective, and then they say, well, you're coming from a place of anger and like just trying to find ways to like discount the experience that we would have. And same thing, they would have like the group that we had, there was people that they realized were Indigenous too. And it was, as I say, it can literally depend on, as you said, who's in the room and if they're committed, and a lot of things. So the diversity training thing, like there's a lot that has to be looked at for sure with that, you know, can't be check marked or anything like that, but yeah. Well, thank you so much. All the comments for Dr. Pam. That's awesome.
And for you. And for this too.
No, I even for me, I'm so grateful.
This has been wonderful. It's been a really nice community feeling to the chat and the discussion. So I really appreciate that.
And just to remind everyone, we will send out, there's a post survey that we can send out with this and a resource list that is attached. And then Kayla also added registration for the next third session that we'll be doing on missing and murdered Indigenous women. But no, I'm just very grateful you were able to join us here, Dr. Pam. And I agree, it was very much a good kind of, I like conversations that way where, you know, these are tough discussions, but the way I kind of view it is like, you know, you have the kitchen table behind you. In our Métis community, we can sit at the kitchen table. It's a safe space and that kind of stuff, you know, and we can talk about like any discussion in that sense, you know, right? We could talk about what we're doing today, but also discussions like today in that regard. So no, I really appreciate it. And I've learned a lot, even myself, just from this session. So I very much appreciate you spending your afternoon with us at the Center for Race and Culture and virtually with everyone who joined us across Turtle Island today.
Thank you. Merci, everybody.
Merci, merci.